Assalamu alaikum. My name is Dr. Azhar Rahman. I'm working as a consultant anesthesiologist in Aga Khan University Hospital. I'm sure everyone can hear me.
Yes, sir, we can hear you.
Yeah. In today's PSA lecture, we have Dr. Huma Saleem with us. She's a consultant anesthetist in Shaukat Khana Memorial Cancer Hospital and Research Center, Lahore. She did her FCPS in anesthesia in the year 2012. After which she did her fellowship from the College of Anesthesiologists, Ireland in the year 2018. After which she did Masters in Quality, Patient Safety, and Clinical Human Factor from the University of Edinburgh, UK. So we welcome Dr. Huma Saleem. She will talk about the perioperative myocardial injury today. Meanwhile, I will request to all the listeners to please silence their microphone of your cell phone during this lecture, so as we can have a minimal disturbance. We welcome Dr. Huma Saleem.
Thank you so much, Dr. Azhar, and thank you, Dr. Asma, for inviting me over for this talk. Thank you, PSA, for organizing these very informational and educational updates in anesthesia. It has been quite a success from the number of participants in the previous sessions, and hopefully things will go on in the similar manner, and we will go on exploiting the social media platform for virtual study programs, as we are already doing, and take example from Karachi sector as well. So today, this evening, I will not be actually dwelling much onto the talk. We would actually like it to be more interactive. So we will be discussing perioperative myocardial injury. Now, perioperative myocardial injury, to understand perioperative myocardial injury, it is very important for us to actually see what do we mean by the term perioperative myocardial injury. So I have no conflict of interest to declare. And my target audience are the lovely people who have joined us on a Monday evening after fighting the Monday blues. The clinicians from ICU, from anesthesia, surgical oncology, internal medicine, cardiology. People, thank you so much for being here with us through the session. And if we have paramedical nursing from critical care and PACU, hopefully they will benefit from the talk as well. By the end of our discussion today, we will be able to actually view, stratify, and review what we actually mean by myocardial injury. Is it viewed as a continuum? It is viewed as a continuum of clinical features from asymptomatic to fatal or near fatal experiences. We will be able to stratify the cardiac risk in patients who are presenting to us for a non-cardiac surgery, and we'll be able to review our management options if this so happens in our patient cohort. So first of all, in understanding the problem, we need to understand its bulk and it actually define and characterize the disease. So defining and understanding, we find that it is actually an eclipsed epidemic. An epidemic because non-cardiac surgery is actually being done for a big cohort of patients who do have cardiac problems. And the cardiovascular management of these patients is very challenging. That is why it is an area of widespread clinical interest. Widespread interest in increasing age numbers as well as increasing number of comorbidities actually involved in these cases. So we actually have to see how we have to risk stratify and then manage these patients accordingly. The 4 decades of research have been done. Immense work has been tried to be done to avoid these problems of myocardial injuries during the perioperative phase. And the research has revealed that there is a diversity of incidence. The diversity of incidence ranges from 0.3%, which is quite less, to a wide range leading to a 16% incidence. So it is a major cause of short-term and long-term morbidity, mortality, increased in-hospital stay, increased in-hospital stay costs, and then accounts for 12 to 40% of our cohort of patients who actually die in patients. Literature also elucidates this problem that the main burden of perioperative myocardial injury can only be unmasked only when we characterize the disease spectrum and we make a sound agreement on the SAY process. So Vision trial was undertaken. Vision trial was done by Abbott and Tom along with their colleagues, and they did it in 2 cohort sets in 2018. The first Vision cohort was actually taken for about 16,000 patients. And these 16,000 patients were in 8 countries in 12 different hospitals. This cohort included patients who had an age bracket of 45 or above, were undergoing a non-cardiac surgery under general or regional anesthesia, and were at least staying in the hospital for 1 day in the post-surgical period. Out of these, they actually followed the patients over a series of tests and biomarkers using troponin over 3 days, and they did serial ECG monitoring over these 3-day period as well. This cohort revealed incidence of myocardial injury in 7.9% of patients, with 2.8% sustaining myocardial infarction, and 2% died within 30 days of surgery. In their second cohort, they included more than 15,000 patients and tried to follow the same protocol and actually tried to develop a prognostic relevance of the said biomarkers to the mortality and morbidity in these kinds of events. So what they tried to do is to establish the relationship of elevated troponin levels with the mortality percentage and its risk prediction. So if we can see that in the second cohort, they found that if the troponin levels were less than 0.01 nanograms per mils, the mortality risk was 1%, which increased to exponential 16.9% when the troponins were increased to 0.3 or more. So therefore, we can see that there is a prognostic relevance between the biomarkers which we employ and the serial ECG testing, but how can it actually see whether this is an injury, whether it is proceeding to an infarction, or whether it might lead to a fatal or a near fatal experience? So for this, we need to characterize the evolution of the injury. The myocardial infarction, we all know, is a characteristic rise and fall in cardiac troponin levels with at least one value higher than the 99th percentile of the upper reference limit. The upper reference limit, which most of the studies take, is more than 0.014 nanograms per mils. But myocardial infarction also requires some of the other features to be present as well. So out of the features which can be present, at least one should be there, like ischemic nature of chest pain, a recently significant ECG change in ST segment and T wave alteration, a left bundle branch block or presence of pathological Q waves, a new onset wall motion abnormality detected on echocardiography, or an intracoronary thrombus demonstrated on angiography or autopsy. The perioperative myocardial injury is very difficult to diagnose, as mostly it is asymptomatic. Once our patients are given analgesics, which might mask the symptoms of ischemic nature of chest pain, the patients are undergoing procedures under sedation or are under general anesthesia. The ECG changes which are seen are either very transient or subtle. Isoenzyme forms like CKMB have limited specificity and sensitivity because of the associated skeletal muscle injury with the surgical process. So how we actually go about it is very tricky and very difficult. Badner and his colleagues found that perioperative myocardial injury is so difficult to detect that it gets delayed in its recognition, mostly recognized around postoperative day 3 to 5, leading to its high attributable mortality, and thereby affecting the prognosis in 30-day and 6-month survival. And myocardial injury post non-cardiac surgery means is even prognostically more relevant to the serial monitoring of troponin levels, because if troponin levels are elevated, with a ischemic cause underlying it, then this has direct prognostic relevance. And this means can be diagnosed even in the absence of clinical or ECG criteria for presence of perioperative myocardial injury. Because of this wide characterization of different disease evolution criteria, Joint Task Force undertook the development of a generalized consensus of definitions for these entities. So they defined myocardial infarction as a clinical or pathological event in the setting of myocardial ischemia in which there is evidence of myocardial injury. And myocardial injury is the evidence of elevated cardiac troponin levels with at least one value above the 99th percentile of the upper reference limit. But the clinical manifestations do not need to be present. While myocardial injury in cases of patients who are presenting for a known cardiac surgery, myocardial cell injury occurs during the first 30 days after a non-cardiac surgery due to an ischemic etiology, when there is no other plausible explanation for the elevated troponin is labeled as MINS. So now we see there is a myocardial infarction, there is a perioperative myocardial injury, and then there is myocardial injury after a non-cardiac surgery. So there is a broad clinical spectrum. In order to read into the clinical spectrum, we need to see what is the pathophysiology of the disease. How does the disease actually evolve? So the pathophysiology in most of the cases is via the rupture of the atherosclerotic plaque. We are all familiar with the atherosclerosis, its process which causes that plaque formation on the inside lining of the blood vessels. But Campus and his colleagues, they found that in nearly 50% of the patients, the perioperative acute coronary syndrome, which occurs, is evidenced by the presence of a plaque rupture. Now, this plaque rupture can be attributed to different things, like it can be attributed to the surgical procedure itself. It can be attributed to the risk of the patient who is undergoing surgery. It is attributed to the disease nature of the vessel walls prior to the surgical procedure. But they found in a meta-analysis, the non-biased judges were allowed to look into the study and to see if the troponin levels are elevated because of non-ischemic causes like pulmonary embolism, sepsis, or cardioversion. They still found that in 85% of the patients, plaque rupture is the cause of the acute coronary syndrome to occur in the perioperative phase. So coronary demand supply imbalance, very commonly seen in our practice because we have a cohort of patients with advancing ages, with multiple comorbidities presenting for complex surgical procedures. So MINS is relatively more frequent, 8 to 19%, but still you can see that there is a big range here, 8% to 19%, it is almost doubling in its percentage. So there can be various reasons for MINS diagnosis, because we see that it is very difficult to diagnose. So different parameters diagnose myocardial injury. So if perioperative myocardial injury is diagnosed in 40% cases of MINS. So if the person has evidence of elevated troponin levels in the perioperative period, then he has 40% chance of having a perioperative myocardial injury. And this perioperative phase is characterized by sympathetic tone changes, cardiovascular system performance changes. There will be changes in the inflammatory milieu and the coagulation profile. All these lead to alteration and change in the morphology of the atherosclerotic plaque, its function, progression, and thus its rupture. So absence of a timely resolution leads to perioperative myocardial injury. The various factors which offset this balance may be a decreased oxygen delivery to the coronary circulation, maybe an increased demand because of tachycardia, hypertension, diastolic hypotension feeding the low supply to the blood vessels of the coronary for the coronary perfusion, or there may be idiopathic coronary arterial spasm. There may be coronary artery vasoconstriction secondary to hypocapnia, All these factors will lead to a decreased oxygen delivery and offset the balance of demand supply in the coronary circulation. The increased oxygen requirements are required because of the increased sympathetic stimulation. There may be tachycardia, hypertension, increased myocardial contractility demands, and increased preload and afterload. So with all these factors taken into account, we know that if it is caused by atherosclerotic plaque rupture, we need to see which population is at risk, which population cohort is more at risk of having this atherosclerotic plaque rupture, of having these ischemic changes, and which may lead to a long-term prognostic fatal or near fatal event for these patients. So for this, we need risk stratification. And risk stratification is done on the basis of predictors. So the revised cardiac index, cardiac risk index is the most validated score which we use, and it employs 6 independent predictors for prediction of a major adverse cardiac event. The 6 predictors it includes the type of surgery which is being done, either it is a high risk vascular surgery, an open intraperitoneal or an intrathoracic surgical procedure, whether the patient had a history of ischemic heart disease, whether the patient had cardiac failure beforehand, if the patient had any history of a cerebrovascular event, diabetes mellitus requiring insulin, or patient had a preoperative serum creatinine of more than 2 milligrams per day. So one can see that from these 6 independent predictors of MACE, we can see that if no risk factors are present, the risk of having a major adverse cardiac event is 0.5%. But if 3 or more risk factors are present, the risk increases to 9.1%. So it is the most validated of all the risk indexes which we use. In addition to it, for prediction of these high risk cohort of patients, various trials have been conducted, like the CARP trial. They included age as a marker of patients having high risk of having a major adverse cardiac event. Then in addition to it, they also included vascular procedures, especially the abdominal aortic surgeries. They included pre-existing diseases like diabetes mellitus, angina, or a baseline ST segment or T wave alteration, which is an independent predictor of a patient having MIMS. The POISE trial also predicted 2 independent predictors of an increase in heart rate more than 10 beats per minute above the patient's baseline heart rate, and a bleeding which requires more than 2 liters of blood units transfused. Perioperative hemorrhage was also found as an independent predictor of myocardial infarction and stroke in United States National Surgical Quality Improvement Program, and it included data from 2005 to 2009. Then POISE 2 also extended onto the risk factors, and they included the CARP trial findings in themselves as well. So in addition to the increased risk of bleeding, a history of coronary artery disease, peripheral arterial disease, congestive cardiac failure, less GFR, and an age number of more than 75 years is also included in the predictor for risk stratification of high risk group. So now we have stratified, we have identified, and we have predicted the risk. So all these actually come down to one thing: how will we actually clinically manifest? What kind of clinical scenarios will we encounter when the patient has a perioperative myocardial injury? So what we encounter is asymptomatic in 65%. And this asymptomaticness actually validates more testing, more screening, and this actually requires more multicentral trials to be undertaken so that a lucid response can be achieved from the consultant body, and a consensus can be reached on how to handle and treat these patients. It is therefore recommended that all patients who are predicted to have risk, who are suggested of having a suspicion of myocardial ischemia, should at least receive a 12-lead ECG and serial troponin measurements in order to stratify them to be followed more closely during the perioperative phase. So how can the screening be done? Screening can be done by a variety of ways. We can use the clinical indicators, which can be evident only in myocardial infarction. But in case of injury, we need to rely on to the biomarkers. So what biomarkers which we use, which are to be used, there is no general consensus. Like we found a consensus on the disease characterization, but the consensus on how to screen the patient is still lacking. In 2014, the American College of Cardiology said that there is no use of using troponin or 12-lead ECG in combination for post-operative risk assessment in these high-risk patients. But the Europeans and the Canadians still believe in tracking the cardiac troponins in high-risk patients in the preoperative phase, as well as for 48 to 72 hours in the post-operative phase. The Canadians do not go more with the preoperative workup with troponins, but they still believe in 48 to 72 hours tracking of the high-risk cohort with troponin levels. So we have talked about the importance of biomarkers because we are left with the asymptomatic 65% subset, which will not present with any symptoms, but we need to see if they have injury to predict their outcome. So troponin is the baseline preoperative cardiac troponin should be done in high-risk patients, and it should be obtained at least 6 to 12 hours prior to the procedure, and then should be repeated post-procedurally on days 1, 2, and 3. It can help in identifying individuals with MINS. And this is again important because they do not have any symptoms of myocardial ischemia. ECG changes may be subtle, may be transient, or there may be no ECG changes at all. The incidence can also vary because the sensitivity of the troponin biomarker which we use is also very important in determining the MINS. If we use a low sensitivity troponin indication, the MINS incidence which the meta-analysis found was only 18%. But when a high sensitivity troponin index was employed, their diagnosis of MINS increased by 30%. So yeah, the biomarkers are really important in the diagnosis of perioperative myocardial injuries. Natriuretic peptides, they have little value in screening the patients. They are more of a prognostic testing in which elevated levels are associated with increased risk of major adverse cardiac event at 30 days and 6 months in the post-operative surgical period. So what do we prognose? How do we see the prognosis of the disease? How does the disease takes its spectrum? So we see that 65% asymptomatic patient subgroup will have short or long-term mortality, which is significantly increased. Important independent risk factor is MINS for acute coronary syndrome development. And this was evidenced by VISION trial, which was done in 2018. There might be the benefit of screening, but still this prognosis is debatable. Managed trial, which was done in 2018, is pro-screening the patients for high-risk group. But still the evidence is lacking. It is actually tailored according to the patient and according to the circumstances with which the patient has presented for the surgical procedure. So how do we actually manage? The management is optimal strategy is unknown because of the paucity of data. The data is variable because of the increase in evolution of the biomedical markers which we use, because of the evolution of the care which we provide to the acute coronary syndrome patients, and therefore the data is still lacking, and we still need to develop multi-central trials to actually see if certain management strategy is better than the other. But at the moment, it needs to be individualized and based on the characteristics with which the mechanism of myocardial injury actually developed, the risks of which therapy which we need to administer to the patients, because this patient is a special patient because he is now in the post-surgical phase. And he is not the patient who is at home. He has already undergone a major surgical procedure, and his risk stratification is again very important. The risk stratification of how to see the risk preoperatively, how the risk can be mitigated in the preoperative phase, and how it can be managed and optimized in the perioperative phase. POISE trial recommends that the high-risk cohort should at least receive aspirin and a statin. Oral anticoagulants like a DABI for 2 years for myocardial injury in non-cardiac surgery patients should be done according to the risk assessment of bleeding in the post-operative phase. Managed trial advocates the use of dabigatran, but again, it needs to be tailored according to the procedure which the patient underwent, according to the risk of bleeding associated with in the post-surgical phase, and how the patient is actually dealing with the injury with the aspirin and statin on board. So if the patient has a full-blown myocardial infarction, it can be either a ST segment elevation myocardial infarction, which is a high risk for death, and a bleeding complication as well, because fibrinolytic therapy cannot be recommended because of a recent surgical procedure in these patients. So we need to rely on pharmacological options, which might be beta blockers, might be aspirin or statins. And only for these three groups, we have meta-analysis to back our argument. Urgent primary percutaneous coronary intervention may be done, but careful discussion needs to be undertaken with the cardiologist, with the intensivist, and with the patient and his family to weigh the benefits and risks in the PCI intervention. If our patient has a non-ST segment myocardial infarction, then we need to discern if the patient is hemodynamically unstable or he is hemodynamically stable. If he is unstable, then we need to seek a cardiology opinion, and we need to refer him for early coronary angiography. But if the patient is hemodynamically stable and there is no evidence of recurrent ischemia or ongoing ischemia in this patient, then we can risk stratify. We can risk stratify in the post-procedure. We can do non-invasive testing, or we can do coronary angiography, or we can do both as and when permitted by the patient's condition. If there is myocardial injury, but there is no infarction, still the approach needs to be tailored. We need to find different approaches to the management. We need to have aspirin, statins, and beta blockers on board. The emphasis needs to be still on continuous monitoring of these patients. These patients need careful and constant ECG monitoring, and this should be done for 24 hours to 48 hours, and in some cases still 72 hours in the post-surgical period as well. We need to maintain a demand and supply balance of the coronary perfusion in the entire perioperative phase, extending to the 3 days in the post-operative phase. Risk stratification with reasonable testing is another until there is a clear evidence of elevation of troponin levels for causes other than ischemia is found, should be done. No stone should be left unturned to see if the troponin levels are elevated because of a ischemic chest pain or a ischemic change in the myocardial perfusion, or it is because of some other reason, like it may be because of pulmonary embolism. So rule out pulmonary embolism. The patient might be septic, so rule out sepsis. The patient might have needed cardioversion. Go into your history notes, go into the notes and see if any such procedure was done for these patients. So you need to see if the troponins are purely elevated because of ischemic nature of event or not. And then we need to tailor the plan according to whatever spectrum of perioperative myocardial injury is presented to you. So if you have a myocardial infarction, which is a raise in troponin associated with suggestive symptoms or ECG changes, then treat accordingly, whether it is a ST segment elevation MI, whether it is a non-ST segment elevation MI, whether it is stable, whether it is hemodynamically unstable, whether you need to seek in a cardiology opinion right away, or you can wait for risk stratification and for pharmacological agents to work. Then if there is myocardial injury, after a non-cardiac surgery, you need to have a clear-cut evidence of elevated troponin levels in the post-operative phase when there is no other evidence of non-ischemic elevation of the biomarker. Asymptomatic patients, but in the high-risk cohort, the recommendation is to screen, to predict, and to optimize prior to the undertaking of procedure. And the consensus of most bodies, including the European guidelines and the consensus statement of the College of Cardiology, the Canadian guidelines, they all agree that these patients need screening with a biomarker of troponin. Troponin screening needs to be initiated in the preoperative phase, 6 to 12 hours prior to the procedure, and then should continue into the postoperative phase in the first, second, and third day after the surgery. It is always recommended to perform a 12-lead ECG in all patients who have symptoms of myocardial ischemia. But the role of ECG monitoring in patients who have perioperative myocardial injury or MINS is very limited because ECG changes may not be there, may be transient, may be subtle, or may go back to normal. So the patients who have myocardial ischemia or MINS or any other perioperative myocardial injury, POI's recommendations are to treat them with statins, aspirins, and beta blockers. And percutaneous intervention can be undertaken if the patient is hemodynamically unstable. So any questions from the audience would be very welcome. Dr. Komal and Dr. Azhar, if you could help me
Thank you,
through
Dr.
this
Huma.
session.
It's indeed a very useful talk it was. And from this topic is not only useful from the examination point of view, but also from the practical aspect as well. So there is a question, hand is raised by Dr. Syed Mohammad Shah. Please unmute yourself and ask your question. Syed Mohammad Shah.
I'm Dr. Syed Mohammad Shah.
जी
Can you hear me, madam?
जी जी ये जी बताइए जी do proceed with your question please. सैयद मोहम्मद शाह, मुझे लगता है कि your mic, your voice is mute from your end.
Madam, can you hear me?
Yes, I can. Thank you.
Madam, my question was that if a cardiac patient goes non-cardiac surgery, in books it is written that patient has a very high risk of post-operative cardiac injury at the third post-op day. Madam, why it
Yes.
is third post-op day? Why not first or second or any other day? Thank you, madam.
It actually, yeah, thank you. Syed Mohammad Shah, I think it's not mostly written in any of the trials because the trials actually look into the periods from first, second, and third as a collective one group of or a cohort group of days for which they need to determine the risk. But the third day, mostly in my practice, I think it's because of the return of the fluid milieu and as the compartments start equalizing, then there is a chance of offsetting this coronary perfusion demand and supply imbalance. So if the imbalance is offset, then there is a chance of developing coronary perfusion abnormality. And if there is a coronary perfusion abnormality, it might lead to ischemia, which can worsen the cardiac event or cardiac injury. I hope it helps you through the question, or if you want some further explanation.
Okay, thank you. There is another question by Mujahid. In the message, he's asking about, will patients receiving regional anesthesia have an impact on the early diagnosis of MINS?
Well, the diagnosis of MINS is not related to the type of anesthesia the patient is being provided, because mostly if the patient is undergoing a regional technique of anesthesia, we also provide sedation to them. And this sedation might actually mask some of the symptoms which the patient might have as a result of a myocardial injury. But then again, if we are talking about myocardial injury alone, we need to find in the fact that it is asymptomatic. It is asymptomatic in 65% of the patients who actually develop this injury. So it is more likely that you need to actually stratify and screen these patients preoperatively, prepare them beforehand before they come in for the procedure, rather than actually diagnosing it on table or after the in the post-operative phase.
Thank you. I'm sure your question is well answered. Any other question from the participants? Yeah, there is another question by Tariq Mahmood. He's asking about non-cardiac patient for non-cardiac surgery, introp use of TE recommended or ECG is enough. So actually, what I'm perceiving is he wants to know about the use of intraoperative TE versus ECG peroperative. Which one is more sensitive, or what is recommended?
Things are very good diagnostic modalities. So if we use T or we use ECG, they are very good diagnostic modalities, but they only occur if they can be useful only when the changes actually persist. So ECG may the changes which you will see in ECG might not be there or might be very subtle or transient. In echo, it's very unlikely to see a wall motion abnormality only because of an injury. Unless it has developed into a full-blown infarction, it's very unlikely to see if a myocardial injury is evidenced on TEE. So again, I rest the diagnosis most likely through the stratification and through the use of biomarkers, which is troponin. We have to follow these patients serially over time with troponin levels.
Thank you. There's another question by Prabin Sobidi. The question is, whenever we have option between using regional anesthesia and general anesthesia, which one is better?
For the patients who are at risk of having a myocardial injury, no one technique is better than the other. It is how you actually maintain the hemodynamic parameters intraoperatively. The plaque rupture, which I've mentioned, is responsible for 85% of these cases, is actually because of the changes in the hemodynamic parameters rather than technique-based. So if you actually use either one of the techniques is okay, as long as you can actually manage the hemodynamic parameters within the patient's own baseline throughout the procedure, and this actually goes on into the post-procedural phase for the first 48 to 72 hours as well.
Thank you. Hassam is raising his hand. Hassam, will you please unmute yourself and ask the question?
Assalamu alaikum, ma'am. Ma'am, if a patient is having an active MI or active ischemic event and is not maintaining his MAPS, which inotrope or vasopressor should be used? What is the drug of choice for this type of?
Again, Hassan, but this is actually a myocardial injury. So if you have a patient who has developed a myocardial infarction, we have to follow the algorithm. The algorithm, as it suggests, you need to follow it accordingly. Like, first of all, we need to provide 100% oxygen. Then we need to see which inotrope is working well. So in different setups, based upon the monitoring facilities which are available and the post-operative care and the degree of development of the intensive care unit, the most preferred inotrope of choice depends upon the personal experience, but we use in our setup is adrenaline. And along with the adrenaline, we also add on other phosphodiesterase 3 inhibitors if things go really messy and bad.
Ma'am, but adrenaline will cause positive chronotropy, which is a major factor of demand factor. And it will mismatch
but you need,
demand supply.
Yeah, you need to find a balance between when you actually need to provide 100% oxygen, you need the myocardium to work less, but at the same time, help the myocardial muscles to contract, producing a positive chronotropic effect as well. So you need to maintain the perfusion to the myocardium, which is done via adrenaline, because adrenaline supports the diastolic coronary perfusion, and you actually help the myocardial muscle to achieve a positive chronotropy effect as well, to maintain the cardiac output to other organs as well.
Thank you, ma'am.
Okay, Abdullah, Bilal, I can't understand your question. It's better to please unmute your microphone and ask question directly. Abdullah? Okay, so next move to the other question. AR is asking any role of pre-op BNP levels in such high-risk patients in view of recent guidelines. Nice presentation, mashallah. Achha, this is a comment. Yeah, he want to ask about the role of pro BNP.
Yeah. So yeah, the role of BNP has been studied extensively. From 2009 to 2011, there was a boom in search about BNP, and what they found is there is less role of screening tool BNP as compared to the prognostic tool BNP. BNP is more important as a prognostic tool. So it will help you to see how your patient is going to progress after this initial event has occurred, rather than being a screening tool and to help you detect the high-risk population pre-procedurally. So it has less or limited role in as a screening tool, but yes, as a prognostic tool, it is an efficient tool to see incidence of major adverse cardiac event in the post-operative phase. And this can actually predict mortality and morbidity till periods of 6 months in the post-procedural era.
Thank you. So any other question? Please ask. This is a very, very important topic from practical aspect as well as from examination point of view. So please try to clear your concepts here. So it is requested from all the participants to please fill in the feedback form. The link is attached in the chat box. So I think there is another question. What if patient is a known case of chronic COPD that develops perioperative MI? Any guidelines for the level of saturation to be maintained? Do we give 100% FiO2 or less? This question asked by the Muhammad Tariq Munir.
Thank you, Dr. Tahir, for this question. There is no specific guideline for handling a patient with COPD who develops a perioperative myocardial infarction, but the main sets always remain the same. Whenever you are trying to handle a cardiac patient, the goals are actually to maintain the cardiac contractility, to maintain cardiac perfusion, to maintain the preload, to maintain the afterload, and to avoid arrhythmias. All these 5 parameters need to be taken care of. In addition to it, yeah, management of COPD, yes, we can say tailor the oxygen FiO2, but then again, you see when you actually look into the equation of the oxygen content of the blood, you see FiO2 has very little effect on manipulating the total oxygen content of the blood. So tickling FiO2 to a lower side will, I think, have less effect as compared to the maintenance of hemodynamic parameters and better ventilatory strategies employed for COPD and MI together.
Okay, Abdullah Bilal has a question. He's interested to know the role of beta blocker in MI, perioperative MI.
Okay, so yeah, the role of beta blockers is established. The POISE trial actually recruited more than 20,000 patients, and they found that if the patient were put on aspirins, beta blockers, and statins, they actually conducted a study on selective beta blockers, and they used atorvastatin 80 milligrams, and they employed as well low dose aspirin of 75 milligrams, and they found that it is exceptionally beneficial in actually reduces the progression of the myocardial injury in the post-operative phase. So yes, it is important and it is beneficial.
Thank you. So with this, we come to the end. Thanks a lot, Dr. Huma, for sparing your precious time and to deliver such a nice talk, which is quite useful for all of us. Okay, so okay, well, there is another question by
Just
Hafizullah.
popped up, yeah.
Yeah. Okay, this is the last question. Is echocardiography advised in every OPS patient?
No, echo is not advised in any OBS patient or in any other high-risk population unless it is indicated. So the echocardiography is actually giving you a measure of the contractility of the heart, its gradients, its pressure flows, its flow velocities, but actually through the dynamicism of the procedure which is going on in the surgical time, in the post-surgical time, and the kind of effect the anesthesia drugs have on changing the sympathetic tones. Echocardiography as a baseline in all patients is a big no. No, we don't do it like that. We need to find the high-risk cohort, and again, the clinical presentations, the clinical features, the non-invasive testings, the baseline routine chemistries, your special chemistries, if they warrant, then yes, we can go for an echo. But it is not like echo is advised in every obstetric patients or echo is advised in every patient. Yeah, like that.
Thank you, Dr. Huma. So now we are ending our session over here. If anyone has any other question, they can ask us on the email address of PSA Center. There they will get their reply. Thank you once again, Dr. Huma. Thank you to all the participants as well. Thank you.
Thank you, Dr. Azhar. Thank you, Dr. Asma, and thank you, PSA Karachi, for organizing this. Thank you so much.